This is the final portion of the lecture series on the small intestine, and here I'm going to be talking about problems with the small intestinal wall. The first part of this is going to be lesions directly of the wall, so infiltrates of the wall itself. And when there's infiltration of the small intestinal wall, there are a few broad differentials you can think about. One of them is non-septic inflammation, i.e. inflammatory bowel disease. That's probably the most common of these lesions, and radiographically is very similar to the run-of-the-mill functional ileus most of the time. Infection can also cause infiltration of the small intestinal wall. You can see that with bacterial agents. There are also certain fungal agents that can be common depending on where you live. Histoplasmosis and pitheosis are big ones, and they can look a lot like the next bullet point, which is neoplasia, such as round cell neoplasia like lymphoma. So there's a lot of similarities between all these differentials, and obviously your prognosis and treatment plan are going to be very different depending on if you're talking about inflammatory bowel disease or histoplasmosis or lymphoma. Ulceration is another mural lesion. It can be associated with any of those bullet points above. It can be its own thing. So all of these are potential effects of the wall. And any of these can be more focal, more regional, or more diffuse. So there's a pretty wide variety of potential findings here. On radiographs, you may identify an obstructive pattern and a mass when there's an infiltrate. And that's more common with things like neoplasia, whether that's lymphoma, whether that's adenocarcinoma, a lot less likely in things like inflammatory bowel disease. An upper GI series is going to be more sensitive for abnormalities of the mucosa. You can assess wall thickening more readily. You can look for irregular margins of the mucosa. And a lot of times you can better see a mass projecting into the lumen. With ultrasound, you can identify separate layers of the GI tract, and you can kind of sort out roughly where the lesion might be coming from. When there's inflammation, usually the layers stay intact. With neoplasia, usually the layers are disrupted, so that's one way to kind of tell apart the more benign things from the more aggressive things. With inflammation or even infection, survey radiographs may be normal. If anything, you may see a functional ileus, alteration in the gas fluid proportion, mild diffuse distension of the small intestine. With an upper GI series, you may see longer transit times. You may or may not see irregular mucosal margins. Generally, when the margins are irregular, they're not nearly as severe as we end up seeing with neoplasia. When you're talking about neoplasia, depending on the kind of neoplasm, you may see a large mass, especially if it is a leiomyosarcoma, or if it's a carcinoma or adenocarcinoma of the GI tract. If it's lymphoma, that tends to be more diffuse, and you tend to not see that as a discrete mass as often. When there is a mass, it can cause obstruction, and so evidence of obstruction again becomes important. With other diseases, with other neoplasms like lymphoma, you may not see a discrete mass, again, because that tends to be more diffusely infiltrative. Round cell neoplasia is also less likely to cause an obstruction, so that can look kind of more midway between something malignant and like an inflammatory bowel disease. So there's a lot of variation in what you see again. As always, don't try to fully evaluate intestinal wall thickness on survey radiographs. We can have suspicions depending on what we see, but you don't ever want to definitively call a thick wall on survey radiographs. As I've said before, when you see thin ribbon-like gas and kind of in long stripes rather than bubble shapes of ovals and circles, that at least clues you in that there might be intestinal wall thickening, although it's certainly not definitive. A little stronger is when you see irregular margins at the interface between the gas and the soft tissue opacity, because I would expect bubbles to have smooth margins with the fluid that they're in, and so if there's an irregular margin, that suggests that the gas is right up against the wall with no fluid in between, and that most or all of the soft tissue we're seeing is truly wall. So here we have a cat who has vomiting and diarrhea, and this is going to be one of those cases where, you know, we're going to be concerned about wall thickening, although it's certainly not definitive. When I look at a number of these small intestinal segments, they all seem kind of big. There's serosa to serosa there. So there's a lot of tissue opacity of these loops, and even this one here that has gas, and again, the impression of a thick wall. As I just said, some of that could be fluid, so I don't know that all that opacity is truly wall, but there is some irregularity of the margins of the gas as it contacts that soft tissue opacity. So I do have to be concerned that this is truly gas against wall, and if all of that soft tissue opacity is wall, then it is actually thick. If I zoom in, again, I think we can kind of see the same sort of story. Larger small intestinal segments than they should be. This funny ribbon-like gas, irregular margins of the gas, pretty concerning as it turns out for a wall infiltrate, or at least wall thickening. And when I see that, I do think about lymphoma or other round cell neoplasia. If I sneak a little bit forward, though, too, now I see increased soft tissue opacity in the region of the tracheobronchial lymph nodes. And so I was cutting that off before, but now if we have multiple findings, including concern for wall thickening, now concern for lymph node enlargement, and then just an overall decrease in detail in the abdomen. If you look, this is not a skinny cat, so I should be able to see the serosal edges pretty well. And while I can see them, they're pretty ill-defined. So in light of that, now we've got more, this is not what I would expect to see with inflammatory bowel disease. We've got more evidence of peritoneal disease on top of everything else. So now there's even stronger likelihood that this is going to be something neoplastic. With an upper GI series, if there is a mural or mucosal lesion, you should see a mural or mucosal filling defect. Remember, that's a lack of contrast medium where you would expect to normally see it. And so a mass or thickening of the wall will usually project into the lumen and lead to a broad-based filling defect where the contrast medium in the lumen is displaced by the mass. If that filling defect has an irregular edge, then that suggests mucosal involvement. A lot of times I think about adenocarcinoma or lymphoma, potentially other round cell neoplasia. Sometimes we'll see mast cell tumors. And people refer to that appearance as thumbprinting, and this is even more common with lymphoma than adenocarcinoma, but where it looks like someone has kind of put their fingertips or thumb tips along the edge of the contrast medium and looks like little bitten out areas all along the edge. Again, we see that with lymphoma. We can see that with other kind of gross inflammatory diseases, especially infectious ones like histoplasmosis or pitheosis. If that wall filling defect is smooth, then that suggests there's no mucosal involvement, and probably the lesion is coming from deeper in the wall, which is where leiomyoma or leiomyosarcoma or gastrointestinal stromal tumor would tend to come from. And of course, we have to consider extramural mass if it's a mass that's outside the GI tract entirely. So this is an upper GI series in a patient who has severe wall infiltrate, and you can see considerable, severe irregularity of the mucosal margin in multiple small intestinal segments. This isn't that mild, fine, brush-bordered fimbriation from earlier. This is truly a case of mucosal irregularity, filling defects, projecting into the lumen. We go to the VD view and we really see the same thing. Lots of irregularity of multiple small intestinal segments. So it's fairly diffuse, much less likely to be something like a carcinoma, much more likely to be something like lymphoma, or again, potentially histoplasmosis or pitheosis, something like that. Also much more severe than I'd expect for IBD. Usually that will have much smoother margins. Ulcers, when you see them, will show up as lesions of kind of increased contrast medium collecting in the mucosa. So they're kind of indentations in the mucosa. They generally have an irregular margin. They're often surrounded by kind of a thickened area of the small intestinal wall, so there's kind of usually projections into the lumen around them, and then they represent an outpouching or erosion into the mucosa right where they are. Of course, we always have to differentiate these from the normal pseudo-ulcers in the canine duodenum. Those are usually more square in shape, have much smoother margins, and don't have any wall thickening associated with them. So when you see a mural lesion, certainly an upper GI series is your next step if you've done survey radiographs to identify the lesion in the first place. That'll help you confirm that there's a wall thickening, or confirm a mass, or confirm infiltrate. It's still not particularly specific for an etiology, although it can certainly send you in the right direction. Ultrasound is probably more specific for inflammation versus neoplasia. Again, you can look and see, is there loss of wall layering or not? Is there severe thickening or not? And ultrasound could also be used to guide sampling of either the lesion itself or nearby lymph nodes or whatever you need. Ultimately, most of the time you're going to need some sort of sampling to get your definitive diagnosis, whether that's an ultrasound-guided sample, whether that's an endoscopic sample, or whether that's a surgical approach for a full-thickness biopsy. For the last bit here, I'm going to talk a little bit about GI rupture, kind of lumping gastric rupture and small intestinal rupture together because they're pretty similar. A lot of different causes for rupture: foreign bodies, neoplasia, perforating ulcers, post-surgical problems, so lots of different potential issues that can lead to rupture. If you have evidence of a rupture, you have to consider it a surgical emergency. It's going to cause peritonitis, it's going to cause sepsis, and that's a big deal. So if you can't definitively identify where the leak is on your survey radiographs or whatever imaging you have, that's okay. Once you've identified that it is a GI rupture, you've got to go to surgery, and you can figure out where the leak is in surgery, because the images may not end up ever being very specific for the site of the leak. And again, you're going to have to go in surgically regardless. The only real reason to spend extra time trying to sort out the cause of the leak would be if you have reasonable suspicion for neoplasia, and if that diagnosis would lead you to stop right there and not go any further rather than going to surgery. So one very common radiographic sign of GI rupture is peritoneal effusion. That's not a very specific sign though, because we can see peritoneal effusion in tons of different diseases, from pancreatitis and peritonitis for other causes to hypoalbuminemia, right-sided heart failure. So a lot of reasons to have peritoneal effusion. So it's definitely something you'll see with rupture, but absolutely non-specific. A much more specific finding is pneumoperitoneum. If you see free gas in a patient's abdomen, GI rupture is possibly your number one differential, and it's certainly on the short list. Other things to consider are penetrating wounds, rupture of gas-producing abscess, which is very rare because we don't have that many gas-producing abscesses in the abdomen, or recent abdominal surgery. And if you don't have history of previous recent surgery, if you don't see evidence of a penetrating wound, then you're pretty much stuck with GI rupture as the main reasonable differential. Once you see pneumoperitoneum, and you know the dog hasn't had recent abdominal surgery, you're really looking at surgical exploration no matter the cause anyway. So even it is a fairly specific finding for GI rupture, and it is a very specific finding for a dog who needs to go to surgery. To identify a pneumoperitoneum, you need to recognize gas opacity, collections of gas that don't conform to a lumen of a GI tract part. So they're non-tubular shapes, they're in places where you don't see or expect to see the GI tract. And you end up getting increased detail in the abdomen. So where fluid tends to cause decreased detail, now you've got increased detail. You can actually see the serosal edges of the small intestines and other organs better than you usually can. That's a pretty key finding to let you know that there is gas in the abdomen. And a lot of times you'll see that near the liver, near the stomach, or outlining the diaphragm as kind of your final slam dunk there. If you think there's GI rupture, you have a couple of options. Say that survey radiographs are inconclusive, so you're not necessarily going straight to surgery. Certainly abdominocentesis is one thing you can do. Look for bacteria, especially if there's intracellular bacteria. If there are intracellular bacteria, you have a septic abdomen, there's your answer. You may not see much fluid that you can get a needle into, and so that may or may not be feasible. If you do an upper GI series to look for a site of leakage or confirm that there is a leakage, do not use barium, because here you are suspicious of a leak. If you use barium, it's going to leak into the peritoneum, and it's going to cause a raging granulomatous peritonitis, and that's just going to increase the potential for morbidity here. So if you have concern for rupture, use iodine. The downside of doing an upper GI series is that it can take a while for the contrast medium to get to the site of rupture depending on where it is. And it may be tough to see a small leak initially, so it may take a while to get your diagnosis. Ultimately, you may be looking at exploratory surgery. Even if you don't have a definitive answer yet, that might be your diagnosis and therapy. So here we have an example of a cat who has a gastric tube, a percutaneously placed gastric tube, so a PEG tube. The clinician was concerned about peritoneal leakage. And so we have this tube going into the stomach, and we can see this nice sharply marginated tube going from outside the cat into the cat and going into the stomach. And we've got a little bit of contrast medium coming around it. And on this first radiograph, it's not clear if that's convincingly in the stomach. Maybe it is. There's kind of a little bloom out here that may or may not be. So we probably ought to administer a little bit more and see what we get. now we have a pretty definitive answer. This contrast medium is not confined to the stomach or the area of the gastric lumen. It's really throughout the peritoneal space, so this is definitely a rupture of the stomach. Small intestinal rupture is going to look pretty similar. Here we have a dog who has a very distended stomach and proximal duodenum. Decreased detail here in the caudal abdomen, mid to caudal abdomen. I'll go back and get rid of that. At least one small intestinal segment that is dilated with gas and fluid. There's colon, so I know that's not it. So it's definitely small intestine. So it's certainly abnormal, definitely indicative of a mechanical ileus. But as I zoom in, there's a little bit more we need to see. As I look cranial to the stomach, there are odd triangular and linear areas of gas that really don't conform to the shape of the stomach, and they in fact are outlining serosal edges of other organs, like the diaphragm, like the liver. So this is indicative of free air in the peritoneal space. This patient has a pneumoperitoneum. Given that there's a small intestinal obstruction, it's almost certainly due to rupture caused by that obstruction. So just in case you weren't sure you needed to go to surgery for the obstruction, now we really know we need to go to surgery for the pneumoperitoneum and obstruction. So what do you do if you're concerned about an intestinal rupture? If you are pretty positive, you go to surgery. If you're not sure, then evaluate your clinical signs, biochemical data. Does it fit? Does it not fit? Consider repeat radiographs. Horizontal beam radiographs are useful, again, when the X-ray beam is parallel to the floor, because the gas, it'll highlight a gas cap in the non-dependent part of the abdomen more easily. So you can do a VD view with the patient in left lateral recumbency, so lie them on their side and go from ventral to dorsal, or do a lateral view with the patient in dorsal recumbency. So your X-ray beam is going side to side, and then any gas cap should collect up near the sternum in the kind of deepest part of the abdomen. A positive contrast study is certainly reasonable. Again, remember, use iodine, not barium. It's a good way to really see that there is or is not a rupture. You may not definitively identify exactly which loop that rupture is in, but it certainly identifies that there is contrast medium leaking from the GI tract into the peritoneal space. Ultrasound's not your best bet. It's not very good at identifying the site of the rupture, because usually a rupture doesn't lead to two big flapping, gaping wounds. So it can be useful if you want to get a sample of peritoneal effusion. It can be useful to look for a neoplasm or other mass as the cause of a rupture. But for actually identifying a site of rupture otherwise, it's just not your strongest point. So that's it for the GI tract, at least for the small intestine part. What did we learn? Survey radiographs are good for some things, especially identifying presence of obstruction, but they're not very specific for etiology of various diseases. The biggest thing we have to ask when we're evaluating the small intestine is, does this patient need surgery or not? And don't forget, upper GI series, follow-up radiographs, different views can be very useful in your armamentarium for identifying what disease might be going on in the GI tract.